I work with Peninsula Health, and I meant to leave this page here, even it's not part of our guideline today, but it is actually something we want to talk about for the first half of the time, for 20 minutes, because I'm not going to talk only about the management of pregnant women. We want to talk in general about any guideline or the difference between the guideline and the policy and the standard, and how can we modify the guideline to our need or our setting. So how all of this happened, I have been asked by one of our team leaders a couple of years ago to talk about management of pregnant women to the rest of the staff during the peer review. And he offered to help with making this PowerPoint, and he asked me to check the PowerPoint later on if I'm happy with this PowerPoint or not, if I want to remove anything or to add anything. I checked the PowerPoint, everything is fine, and I told them I don't talk about pregnant women without having also the early childhood decay and the sump sucking, so he added it to the PowerPoint. So why I'm saying all of this, to get into a few points to see our experience regarding guidelines, our trial regarding guidelines, what did we do about it at Peninsula Health. That's why I left Peninsula Health there. And I left also all of this there in my PowerPoint to say that it's Peninsula Health. Why? I'll explain that later on. And what we said also, Dental Health Service Clinical Practice Guideline. Why? We will explain that now. So how did it all start, and what we're going to get out of this? I have one of the team leaders approach me, so there's some teamwork. Ask it to do this work, I accepted to do it, so I'm helping with some guideline, making all the clinicians aware of this guideline. So you don't have to do the same like what we did, but you can try to do something to let all your staff able to understand the guideline. For instance, if we have 6 guidelines, and we want to make sure that our staff are aware of this guideline, we can make something like this PowerPoint, and we can talk about this guideline in our peer review. So every second month or so, we can introduce one of the guidelines, so our clinicians are aware of this guideline. So within the year, you can review 6 guidelines, and you're making sure all your staff are aware of this guideline. So what's the benefit we got out of this? Teamwork. All the staff are aware of the guideline. All staff asked questions and happy to go ahead treating patients according to these guidelines. Staff got 1 CBD points, which is important also for them. They can get extra CBD point by going through the Dental Health Service extranet to answer the questions for the pregnancy guideline. Staff encouraged to do the same, and they started to introducing presentation during the peer review about materials, about guidelines. So I have staff started doing the same process and started being active with the peer review and with the team meeting. I have, as I said, staff aware of the guideline, ready to go with the guideline. I have also, for the operational management, that's QIA, quality improvement activity. They can put that on their quality improvement activity. So we had a lot of benefit out of this PowerPoint. But the main benefit here is we modify the guideline to make it simple, digestible, readable. So when you want to get into anything through this guideline, you'll find it straight away. The guideline always a bit dry, very hard to read, very hard to find what you want straight away. The PowerPoint here, it's showing us where can we find it quickly. So modifying the guideline to our need, it's something not bad, as long as you are not changing the content, the principle of this guideline. So that's why we had this PowerPoint, to make it easy for everyone to find what they need. That's the difference between guideline and policy or a law. The guideline you can change as long as you are not very far from the main concept of the guideline. But the law, you can change the law. If you are not following the law, you are out law. You can't. If you are not following the standard, you can't follow. You can't say, I can't follow the standard. As we all know that there are 6 standards came this year regarding the accreditation, and we have to follow them. And we can't tell them, no, we can't, I don't like this standard, I can't follow it. They'll tell you, okay, go home. There's someone else will be able to follow this standard. But the guideline, I can. It doesn't mean every single point with the guideline, I say, no, I don't like it. No, you can't do that. I still can change the guideline, but the law I can't. And that's the difference between any guideline and the law or the standard. You can't say, I can't follow the standard. You can't say that. You can't say, I can't follow the law. You can't say that. But sometimes you can modify the outline, the guideline. But you have to have a very good reason. You have to have a very good standing for why you're modifying the guideline. And I'll show you a few things with guidelines, how people got into trouble using the guideline as it is. The main difference also with the guideline, as we said, you can modify it to minimize sacrificing people. What I mean by that? With the law, any law or any guideline, try to cover as wide area as possible. By covering this wide area, I'll have a lot of casualty. People will be sacrificed because of covering this wide area. Let us take a small example. Couple got married. Marriage didn't work from the first day. They stayed together for 5 years. 5 years they went to court. I'm sorry, the woman took half of the man's money. What happened? The law could not protect this man. He still took half of his money. Even the marriage wasn't working from the start. But if the law tried to protect this man, the change in the law will sacrifice millions of women to protect this man. So there's always casualty in any law, in any policy. But even with the guideline, but I don't have to accept this casualty with the guideline because I can change it. That's the whole idea. I can change it. I'm not a robot. I'm not a computer. I'm, for God's sake, health professional. I have compassion to the patient. I need to do the best for my patient. So if I found the guideline not helping me to do what I have to do to get my duty of care, exactly how I feel about it, don't do it. Question it. Find out what is the right thing to do. You can question it. You can change it. And that's the whole idea. So we are not dealing with standard. We are not dealing with law. We're not dealing with policy. We're dealing with guideline. But it doesn't mean you go now and go back to your work and tell your manager, no, I'm not happy with the guideline. I don't like this. I don't like this. You have to have a very strong reason why you are not happy. We will have a lot of examples with this guideline later on. But I'll give you a small example about one of the guidelines with bleeding. It's away from what we're saying, but just to support what I'm talking about. Patient on warfarin. We're trying to do extraction. Patient INR 3.94. Will I do the extraction or not? Shane saying yes, I'll do the extraction. Some, yes. Okay. I'll tell you what I did, but I'll tell you also 3 weeks ago, one of our dentists got into trouble. during his credential interview by saying yes. 3 months ago, a relative to this dentist did about clearance, got into even worse trouble by following this guideline as it is. Because you need to think about the whole concept. You need to think about the whole patient, not just what's the guideline telling you. The guideline said up to 4 years. That's fine. The first dentist did about clearance. Patient kept bleeding for 3 days. And came back, checked the patient. I found it beyond my ability to do anything. By chance, the maxillofacial surgeon was available around the time. He wasn't very happy. And it's very hard to make a maxillofacial specialist unhappy or angry because their job is very stressful. So they are very calm. But he was angry about it because he had to open the whole thing again, clean everything, put some medication, a lot of stitches, following up this patient in 2-3 days, and bringing the patient back again in a week's time to check what's happening. A lot of work needed. Patient was in trouble. Interview. We have, most of the big organizations, you have this credential interview. This credentialing thing for the dentist is, they consider them the same like specialists because they are able to see patient without supervision. So they want to make sure that this dentist is able to take care of this patient without supervision. So the credential, going through paperwork, going through interview with the board of management of the organization. That's a big interview. And 3 or 6 months preparation period. So during the interview, this dentist was fantastic, was very good, answered all the questions. And as a dentist, I tried to ask him questions understandable by the rest of the board because the board are all medical professionals. So I have to ask questions understandable by both sides. So most of my question about trauma or bleeding. So I asked the bleeding question. He answered very well until he got into the point of INR of 4. They accepted it. When he left, one of the specialists said, I have a heart condition. I take warfarin. But I always keep my NR below 2.5 because I know I'll be in trouble if I exceeded this 2.5. So is this dentist wrong or right? Did he do the right thing by saying, up to 4, I'll do the treatment or not? It's all answers are right. Yes, he can, but don't push your luck. You need to be reasonable with your treatment. If the patient said, yes, I am bleeder. When I touch anything, I bleed. When I do this, I bleed. And you're pushing your luck and doing the extraction. What do you expect? And not only single extraction, you're doing clearance. What do you expect? Saying that, I've done that 6 months ago. But there was different circumstances. It was the end of the APC program, the Enhanced Medicare. And this patient had heart condition, young man, 40, 42 years old, had heart condition, had an heart surgery, and really medical compromise, but strong. He needed to have our 6, 7, 8 extracted, and lower 7 and 8 extracted. His doctor, his GP, asked me to refer him to maxillofacial specialist. I spoke to the maxillofacial specialist. He said, yes, it's better to refer this patient to me. I spoke to the patient. The patient doesn't want to go to the maxillofacial specialist. He wants me to do the extraction for a lot of reasons. First reason, he's very scared. Can understand that. he can't pay the difference, the gap, which I could send him to a specialist without paying gap. Can't drive distance. He can't go to the specialist. He wants me to do the extraction. Patient is well aware of his condition. Wife is very aware of his condition and how to take care of him. Patient is well aware of any possible complication. Patient history, not really bleeder, but his reading was 3.9. Should I do it or not? Don't forget, this was almost surgical extraction. So I'm doing 3 extraction surgical at the same time as with EPC, something around $550. So why should I leave this big money for someone else? That's the cream of the business. But that was the last thing I thought about. But it still kept encouraging me to do it. But I didn't do it without knowing 100% that I have a safe patient. So yes, I did follow the guideline, but I was very careful following it. This patient had the clearance, the 6, 7, 8, upper 6, 7, 8 done, was fine. He came back the next time. He was happy. He has these lower 7 and 8 done. Very easy, no problem. Half an hour each appointment is all done. So yes, you can do it, but you have to be more careful how you follow the guideline. Not every word in the guideline, you can do it in your sitting. Different sitting allow different things. And that's why when we started talking about the guideline, it has a more wider coverage. But it doesn't mean this coverage is going to cover you. The other thing also, this guideline cannot protect you 100% in court. If it's standard, if it's low, it's different. But the guideline, I don't think it can. Am I right, Shane, or not?
Well, it certainly wouldn't cause you any grief.
Yes.
If something went wrong, if you were able to demonstrate that your treatment was within clinical guidelines, but you're right, it's not absolute.
Yes. So it's not absolute support for you. So before you say, I follow the guideline, you have to ask yourself, did I do the right thing or not? Because at the end of the day, no one going to be asked about what you did. No one going to say, no, the guideline is wrong. No, you will say, you did the wrong thing, not anyone else. Because you have the brain to think about if that is safe for your patients or not. So it's not the guideline. If it's policy, if it's standard, if it's a law, it's different, but not the guideline. The guidelines support, but not protect. It's support, but not protect. That's different. So that's why we need to think about the guideline. As I said, it doesn't mean we be pain in the neck for our management to tell them, no, I'm not happy with the guideline. No, we have to have a very good reason why we are not following the guideline. We'll go through the guideline here and we'll see how quickly we can go through it. Because it's PowerPoint, it's point, 1, 2, 3, 1, 2, 3. I'm getting a bit old and I can't remember everything very quickly. It's truly, I have early dementia. And most of us will get into this very soon. We studied that 20, 25, 30 years ago. And to have the same capacity of remembering things, it's almost impossible. So what stays with us, the experience, more than remembering things. And that's what keeps us still in line. Our experience keeps us still working, but not our memory. So for our memory to cover up quickly our loss of memory, we need to have something simple to get into it very quickly. Yes, 1, 2, 3. Yes, I know what I need, that's it. But to go through the guideline, very hard. Let's see. So priority access. We'll go through quickly a few things very quickly, but I'll stop in certain area which I have a bit more interest in it, because this is a critical area. We always advise the pregnant woman about periodontal disease, and we know how periodontal disease can cause problem, and the bacteria can go through to the baby and transfer this Streptococcus herpes and the lactobacilli to the baby. Best way to help to stop that oral hygiene instruction, we'll talk about that later on. It's very important, one of the most important area about pregnancy, oral hygiene instruction, and talk to the parent, the mother or the pregnant woman, what to do during this time. And they use the CPP and ACP product. Does anyone know what's the CPP or ACP? Fantastic. Casein phosphopeptide and amorphous calcium phosphate, yes. What does this do? This actually, it increases the calcium and phosphate ions in the oral cavity. So it bonds to the plaque and bond to the teeth, and increase the saturation of the calcium and phosphorus ions, free ions, and when the plaques start demineralizing, it reduces the demineralization and enhance the mineralization. So it has a very good, strong effect to stop dental decay. And by stopping the dental decay, stopping the extra cariogenic bacteria, which can pass through the placenta and go to the baby. So it is a very good way of stopping this cariogenic bacteria through the tooth mousse or the chewing gum. As we said, education to the mother about the periodontal disease and how it affects the baby. Oral hygiene is very important. As a way of prevention, to advise about the diet. The diet also is a bit, that's again about guideline, how it's changed every day. I remember 20 years ago, I used to tell my patient, no, don't have fish and chips. Because at this time, fish and chips, the fish is shark, small shark, yes, but it has a lot of mercury and magnesium and minerals, and not really the favorite one. But that was the trend at the time. But now all the studies saying, no, it's not. It's what we have in fish and chips is very, very limited, because this shark is very small shark. So they are not old, it's the old fish. It doesn't have to be shark, any old fish, any aged fish can have this amount of mercury or magnesium or any minerals which is not wanted during this pregnancy. So advising is very important, which, as I said, it can vary from generation to other generation, but at least we know that milk is very good, cheese is very good, nuts is very good. Cheese is very good because it has a buffering action, and it can neutralize the oral cavity and changing the acidity from acid base to either alkaline or neutral. Acidity, I'm not sure if we pass this area or not, about vomiting, and we might come back to it later on. But with vomiting, a lot of acid coming, and now it's always in an acidic situation. We will see what we can do about it later on anyway. But one of the things is the diet, cheese, milk, this will help. Other sort of treatment also, facial sealant, of course, cleaning, removing the plaque, having treatment plan for this pregnant woman, and oral hygiene advice for the infant, and when the baby comes. And that's why I always talk about early childhood, some sucking with any pregnant guideline. So one of the things with the oral hygiene instruction, we talk about the baby. We talk about when the baby comes, what we're going to do. What's the best time for the baby to visit the dentist? Do we know when is the best time for the baby to visit the dentist? it's 12 months old or 6 months after the first eruption of the first tooth. First eruption 6 months, 6 months after will be 12 months. It's better to check the baby 12 months old for two reasons. One reason is to check if there is too many decays, is something wrong happening. So this needs to be treated. And the other thing is to see what's the mother doing, because most likely there's something wrong the mother is doing. What I mean by this? Lot of time, the mother, especially the first baby, drive her mad. Can't sleep. Can't have 1 hour just for herself. So she wants to put this baby to sleep by any way. So what do? You put some honey, you put some anything on the dummy, let the baby sleep. Don't worry about what's going to happen. I don't care. I just want this an hour. I don't care what happened. I want this an hour. We need to check that because you will see. You'll see most of the teeth getting decayed because of that. Anyone in this situation might think this way. Even we might think, because we are from outside, we don't see how much she's suffering. We say, this is cruel, you shouldn't do that. Sometimes, if you are in the same situation, you might do worse. I'll give you a small story with my family. My grand auntie, the oldest auntie, she's probably 11 years older than my father. When my father, the story I'm talking about 85 years ago, so none of them would be unhappy about it. So he was a baby, probably 2 years old or something like that. She was still 12 or 13, and she wants to play with the other kids. And her mom left my father with her to take care of. What she's going to do with a 2 years old baby? And she wants to go to play with her sisters and the neighbors. What's she going to do? So what she did, she opened the door, she found a bottle of brandy. So she put it in the bottle. Truly, she gave him brandy. She slept for a day. He slept for a day. Yeah, he kept sleep for a day. That's why he loves the brandy all his life, probably. Yes. Yeah, she did. So that's how the people think. It's not strange for people to think this way, but it's strange for us because it's our profession. We worry about the teeth, but we don't see the other side. Why it's happening? We need to see all aspects. We need to be able to advise people about something. We need to see how they feel about it. We need to make sure that they can do it. Like when we talk about to people, stop smoking. He's not going to stop smoking. Smoking is not good for your health. He's still not going to stop smoking. You need to be more convincing. You need to feel about him also. I was a smoker up to recently, up to 2 years ago, and I stopped smoking. But yes, it's not easy. It's not simple. So when you advise someone, you need to feel the other side. So your advice goes through. Back to here. Sorry, we went too far. Questions. Question about, we'll go through these questions very quickly. We need to know about any complications of pregnancy, any vomiting, because as we said, if there is vomiting, we need to do something about the hyperacidity of the mouth, which we'll show later on. Sodium bicarbonate mouthwash will help a lot to minimize this low pH, so to make the field more alkaline. Smoking also, pre-existing condition, very important to know what they're doing at home, the home care, to know if there is any X-ray available instead of going through the X-ray. We'll talk about the X-ray later on anyway. The dietary, what they're eating, if they're eating too much carbohydrate or any acidic food, and time of consumption, frequency of intake, what's happening here? We always hear about pregnant women eat too much. They don't eat too much. They eat almost the same like us. But the bigger the baby, the more compression against the stomach, makes the stomach a bit smaller, making the pregnant woman unable to have a full meal. So when they eat 1/4 of our normal meal. So this way, to have our meal, they need to eat 4 times. So by eating 4 times, it's one of your meal. It's not a full meal. And by having this way, they, let's say, eat 10, 12 times a day, including snacks and things like this. So do they clean their mouth after each meal? I doubt it. Do they eat too much more than it should be? I doubt it. It's just we need to talk to this mother, to tell them what's happening, explain to them that what they need to do. They need to give a bit of extra care to their teeth, extra care to their gum, because this is what's happening. They are still normal. They are not alien. Being alien, we alienated them. Truly, we alienated them. They are not alien. We alienated them. And one of the pages there, we'll get into it very soon, I'll show you how we did alienate them. They are not medically compromised. They are normal people with big tummy. That's all. Yeah. You just need a bit extra precaution. That's all. But they are normal people. This is the beige one. This is the best one. This is the best one. We'll stay there for a while. I just say they are normal. Let's have a look at the first one. Pregnant women who are at risk of infection endocarditis. Primary prophylaxis is amoxicillin 2 gram. And if they are allergic to amoxicillin, clindamycin 600 milligram. What does that remind you with? Normal patient has the same. So there are not any difference. I'm not doing anything extra. It doesn't worry me to give them 2 grams penicillin. It doesn't worry me. It doesn't worry me to give them 600 milligrams clindamycin. It doesn't worry me. There are very, very limited medication which we don't use it in dental, might interfere. But most of what we use, you should be fine. And you shouldn't be scared or worry treating pregnant women. The better is coming, the same page. No increased risk of preterm birth or miscarriage or anything associated with essential dental treatment. What does that mean? Okay, before we go further, what does that mean? What's essential dental treatment? Presence of moderate to severe dental caries, fracture or abscess teeth. So this is essential dental treatment. There is no risk of treating this patient. Does that mean there is risk if I did this treatment if they are not suffering from this? So if this patient not in pain or doesn't have any abscess or infection and I treated her, she will be in risk? Don't think so. She should be actually in more risk when she has all of this. So no risk, this phrase does not prove the other way. It doesn't say there is risk. You understand what I mean? When you say no risk with essential dental treatment, it doesn't mean there is risk with general dental treatment. It doesn't mean that. But it's just trying to assure you that you are fine. Don't worry. Just do the treatment. It will get worse later on. Just to keep going on this page. No association between maternal and general dental care during pregnancy and gestational age, birth weight, or neurodevelopment. So it's giving me a free hand to do any treatment, anytime. We agree about this? free hand to do any treatment, anytime. That's the statement of the guideline. This PowerPoint coming from the guideline. Let's go to the next line. Most comfortable and safest time to treat pregnant women is during the 14 to 20 weeks of gestation. So started limiting me now, telling me, no, that's the best comfortable time. The next two lines even worse. Elective dental treatment should be avoided during the first trimester. Elective dental treatment should be avoided in the second half of the third trimester, as premature birth is at risk. When I hear that, the first thing I would do when I go, I put a sign in my surgery: no alien and pregnant woman allowed. That's it. Yeah. What does that mean? Is the guideline wrong? It's telling me clearly you can't touch them. You're facing explosion. You can't touch them. The guideline is not wrong. They just used a bit much wording. Even during the Clinical Leadership Council meeting last week, I did comment about this. Should be. It's too strong word. Should be preferable. Should be advisable. But you can't say should not. It's too much. And because of this word, I have 50% of pregnant women in the area being referred by young private dentists. They don't want to touch them, because of just one word in the guideline, saying should be avoided. Misunderstanding is the concept of the guideline. The guideline, you take the spirit of the guideline, not the wording of the guideline. The spirit of the guideline is trying to help you to cover every aspect, but cannot give you all the circumstances. So try to tell you essential dental treatment is fine. Don't worry about it. But what's the difference between the essential and the elective? It's all dental treatment. Can't see any difference. It's all dental treatment. Why is the guideline telling me should be avoided? The guideline trying to tell you don't push your luck. That's the whole thing. The guideline is not wrong. Don't tell me a patient during this time asking you, if you are a maxillofacial surgeon, to have jaw reconstruction. For God's sake, it's not the time for the jaw reconstruction. Just after or before is okay, but not this time. You can do it some other time. So don't push your luck. Saying that you can. If you have to, you can. But if you have to, if you can justify that, let's say this is the same person who I'm saying don't do it, had a car accident. Will they do it or not? They will do it. Because they have to do it. But you don't have to do it if the patient is just normal. It's just wait. Don't push your luck. Wait. So there are things you need to do it, but think about it before doing it. And there are things, don't do it. Don't do it. You don't have to do it. Think about it before doing it. You don't have to do it. So the guideline is not Bible or Quran. It's not God. The guideline is there to help you to make the right decision, but not to force you to make a decision, because at the end of the day, it's your decision. It's not the guideline decision. And you will be responsible for this decision, not the guideline decision. So you need to be comfortable about the decision you made, about the treatment you're making. Amalgam restoration also is very safe if it's handled properly. There's no problem about this. Pregnancy granuloma. It can happen to 5% with a patient. You don't need to interfere, you just monitor it. If it's bleeding or in the way of mastication or if it stays after birth, we might need to interfere. Otherwise, you just monitor it. If you remove it during pregnancy, it's very likely to happen again. So you don't need to remove it. You don't need even to refer to the patient specialist. Just assure the patient this will go after pregnancy. Loose teeth, I've seen this in the worst scenarios last year. Patient, not last year, a couple of years ago, because I saw her husband a couple of weeks ago, and I asked him about this patient, and he told me she's fine. All her teeth moving like this. I never seen something like that. All her teeth moving like this. Yes, I've seen it. You don't see that every day. Even you think this patient, the most couple of weeks, she's going to lose all her teeth. It was like a severe periodontal mobility. It doesn't have to be as what I'm saying. That's the very severe side of it, but it can happen. But after pregnancy, after having the baby, should be fine. And this patient still has all her teeth. So this mobility, it can happen. Don't get scared about it. Don't get too worried about it. Just assure patient that it's normal with the increased level of the estrogen and progesterone. It can happen, the periodontum get affected, and the teeth mobility is very likely to happen. But she is not going to lose her teeth. And ask them, don't play with the teeth and keep shaking them. Just leave it, leave it. Yeah, because people tend to do that. Yeah. Excessive salivation and dry mouth can happen either way. Just assure the patient also it's just temporary thing. It can happen. If there is dry mouth, there is dry mouth gel they can use, or the sugar-free gum. With the acid erosion, as I said, we need to increase the pH. So to change from the high acidic level, which most likely going to be around the 2.5, we want to increase it to at least up to 6 by the sodium bicarbonate mouthwash. Medication, we need to take the therapeutic guidelines, which is not our area at the moment. Again, the therapeutic guideline is a fantastic book, talking about most of everything. But there is a lot of argument about what's written there, especially about bisphosphonate. Oh my God, this explosion, bisphosphonate thing. That show you how much the guideline can change easily. It doesn't mean you don't trust the guideline. It doesn't mean you don't follow the guideline, but it means that it is changeable. And you need to use your mind before following it completely. You need to be happy about what you're doing, not saying, I'm following the guideline, and that's it. Let the patient die. I don't care. No. I remember something, presentation happened. I attended a presentation a couple of months ago, a young dentist presented a very good case study, sorry. And talking about this patient needed antibiotic, he refused to take the antibiotic. Hang on a second, no. Yeah, this patient wanted the antibiotic, but the dentist knew the antibiotic is not going to work very quickly, so they need to be hospitalized, swelling like this. And the whole idea is, once she spoke to the patient, she's bonded to this patient, that's it. There is duty of care. Patient died, car accident, got some sort of dizziness and coma while he's driving, and died. What is her responsibility? The whole idea for this young dentist was legally and right. That was the most important thing for her. Legally, she's right. She's tried to advise the patient. She's tried to do this and this and this, and patient got angry, doesn't want to listen to her, doesn't want to go to the hospital, he just wants the prescription and go. That's formally your duty of care is okay, but would you feel comfortable doing it? That's the difference between following the guideline and taking the spirit of the guideline. You didn't do what you have to do. Patients died. You could do better. You could call the police and tell them this man driving this truck and he is dangerous. He's going to die. You could do that. You could take the patient to the hospital. You could do that. Yes, please. 5 minutes. Okay. Time flies when you have fun, isn't it? Okay. Let's go to it because we have a few things to cover very quickly. Nitrous oxide. It's better not to be used during pregnancy, either for patient or staff, and if staff involved with any treatment using nitrous oxide, it's better to have some sort of excavation or suction. If there is no source of excavation, this stuff should be removed from the area. So neither staff nor patients to be used for. Local anesthesia. We used to have this also old era of don't use tetanus, don't use flipperocin, don't use octopocin. That's dangerous. No, you still can use it. Maximum dose 600 milligrams, which is, I believe, something around 9 cartridge. If you know that flipperocin, you shouldn't use it. You're not going to use 9 cartridge with your patient. So you still can use anything. But again, don't push your luck. If you have something else, use something else. You don't have to use it. If you are not happy using it, don't use it. The guideline telling you, yes, you can use it. You can, yeah, if you want to. Yes, you don't have to. It's all about flipperocin. Supine hypertension syndrome, that's 8%. Does anyone know what's happening here? Just because there's no time, so we'll go very quickly through it. It's the inferior vena cava. It's tilted a bit to the right side. There is only one inferior vena cava, not two, one on each side. No, just one, but bit towards the right side. So we try to elevate the right side to reduce the compression on the vena cava so the blood return to the heart can go nicely. And what happened when they, on supine position or reclining, the blood flow coming back to the heart through the inferior vena cava doesn't go enough, patient collapse. So that's why we elevate the left side, or we tell them to the left, we elevate the right side or tilt them to the left side. Radiograph, 1 MSV, that's a lot. 1 X-ray is 0.22, 0.002, that's a right wing. Periapical is 1. You need 1,000 X-ray to reach to the highest level of safe X-ray, per year, of course. You will never reach this. You will never reach it. So it's safe for the patient, safe for the baby. But saying that, how many times did I take X-ray for a pregnant woman? 0. I'm not happy doing it. Guideline can push me to do it. I never needed to do it, but when I need to do it, I will do it. When I need to do it, I will do it. But I never needed to do it. Only, of course, the maxillary X-ray, because the tube comes this way, so the direction of the beam through the baby, you can't put up when you can't protect it at all. So it's a big no. Don't do it. OBG, I'm not sure, because I challenge you if you find one place will accept your patient to do OBG. If the guidelines say, okay, I challenge you to find one place to accept your patient to do the OBG. It's no way. It's not going to happen. Pregnant patients, not patients, sorry, staff, they can have the monitor to check the level of radiation. We talked about the nitrous oxide. I don't think there will be time for the early childhood carries and the thumb sucking. But anyway, it's very important, as we said, to check the patient 12 months old and to give more advice to the parents what to do and what not to do. Thumb sucking is the same. The kids grow out of it, but it's very important also to talk to the patient about it. Not the patient, sorry, the mother, the parents about it. To do it, to stop patient, it varies from either appliance or putting some bandage around the patient's finger, just to stop the enjoyment of the habit. Stop, the same like the patient who grinds their teeth at night, stops the enjoyment of the habit doing it by having this splint. Stopping from doing it, that's the whole thing. Back home, a while ago, what they used to do, put hot chili in the fingers they're sucking. They suck it only once. End of it, they don't suck it again. That's it. I'm not saying to do that here, because that's child abuse, but there are ways to stop it from happening. Thank you very much.